Um, our next speaker, one of the strong points of our clinical care network is when we organize and schedule these meetings, it doesn't happen by magic. There is a team that works behind the scenes. And part of the efforts of this team is to bring forward potential new presenters that are going to present something that is felt to be important and hasn't been addressed in other avenues that we've had. So it's my very great pleasure today to introduce Beth Solomon, who's going to talk to us about cutting edge research and management strategies for swallowing issues in JIIM patients. So a little bit about Beth. She's the Senior Lead Clinical and Research Coordinator for the Speech Language Pathology Service in the Rehabilitation Medicine Department at the National Institute of Health. Quite some title. Her clinical practices, an area of expertise, encompass diagnosing and managing pediatric and adult dysphagia, head and neck cancers, voice disorders, complex and medical conditions, rare diseases, and craniofacial disorders. She's an active researcher involved in numerous NIH protocols, phenotyping speech, language, and swallowing functions in complex medical disorders and assessing outcome measurements for their treatments. Beth has mentored numerous graduate and medical students during their clinical internship and post-baccalaureate training programs, and is a frequent guest lecturer to local graduate programs in speech language pathology. She's presented at numerous state, regional, and national and international meetings and has over 30 research publications. She holds a master's degree in speech language pathology from Columbia and a bachelor's degree in communication disorders and elementary education from the University of Massachusetts Amherst. And I would invite Beth to give her presentation today on cutting edge research and management strategies for swallowing issues in JIIM patients. Over to you, Beth.
How about now? Can everybody hear me?
You're loud and clear now.
Perfect. Thank you very much. And thank you for the introduction. It's a pleasure to talk to a new group. Some of you are new to me, and some of you are not. I have been working at NIH, and I hate to say this, but I'm becoming the dinosaur there because I'm approaching almost 30 years. So it gives me a long history, lots of diseases, lots of different aspects. But I've been working with JIIM and all the myositis issues and diseases for almost the entire time I've been at NIH, and have had the luxury of working with Dr. Miller, Dr. Schiffenbauer, and Lisa Ryder, as well as Hannah Kim, with the JIIM patients overall. I'm going to just go back. My talk today is going to be a little bit of research, but majority of it is more clinical. And I know we all know about JIIM, but I do want to point out that speech issues are very relevant, as well as swallowing. They are definitely classic features, but they sometimes go overlooked as they're not sought out right from the get-go. We know JIIM and the myositis all have the inflammation. We know we have weakness, but this weakness sometimes does not present right away in the pulmonary, cardiovascular, the oropharyngeal or laryngeal areas, or the gastroesophageal systems. And the question I raise as a clinician and as a researcher is, are we just not looking in the right places, or are we getting complaints from parents more in the limbs and some of the other structures right away? So as a speech pathologist, my biggest concern is, are we safe swallowing? In the pediatric population, that's really important, not only for nutritional support in development, and having to know, do we need alternate feeding methods right from the get-go, especially during the initial stages of the disease or the flares? And when it comes to communication, it's really important that they're able to function just to keep up with the social communication education as we go on. Now, if I just look a little bit at the research that has been done and there has been a lot of research, but majority of the research are review papers, especially when it comes to the oral pharyngeal and the GI issues. Now, Barbara Sunnies, who was at NIH for many, many years, did a nice paper initially on myositis in the 90s, and that's when I first joined in her group. Later on in 2007, McCann actually looked at some of the actual disease features, what I'll call the manual muscle testing, questionnaires, disease activities, to see if there were any correlates with actual swallowing studies, but could not come up with anything at that time. Dr. Ryder's also done lots of different types of papers, including the antibody paper and the phenotype of JIIM. And the list goes on here. But I think one of the most important issues is, what do we do about clinical assessments as it relates to swallowing function? How do we know which assessment? There are so many out there. How do we go about deciding what to do? And then how do we go further in terms of the treatment? So just a few facts about swallowing, or dysphagia, which is the disruption of swallowing. What we all should know is that you and I both swallow 600 times easy a day. More obviously when we are eating, less when we're sleeping, but it's 600 times. And people don't realize that's a lot of work. We know that the New England Journal of Medicine put a leading cause of aspiration pneumonia for death in patients with not only neurological diseases, but also muscular disorders in 2001. So swallowing issues are very, very important. We know with the myositis, we're dealing with both smooth and striated muscles when it comes to the actual swallowing. And we have issues when it comes to moving the food in the mouth, all the way down through the digestive tract, as which times things change in terms of the muscular function. Most people will describe swallowing in 3 phases. The first phase, the oral phase, moving the food, the liquid through the oral cavity. The second phase, obviously, the pharyngeal and hypopharyngeal regions. And the third phase, the esophageal region, all mediated within the brain stem. You can see here, this is an actual swallow. It goes very, very quickly. I'm going to actually go back one second. And if you see, it was 1 second here to here, 1 second here to here. That is normal. When the timing is off, you will end up with more difficulties, and I'll go through that in a minute. Now, when it comes to JIIM, complaints of swallowing, as I said earlier, are not the primary concern. Doctors it's not one of our first leading questions. However, we have to listen to our patients. Swallowing complaints typically are, I'm not hungry. I can swallow, but I'm not hungry. We start avoiding foods. The foods that we start avoiding are more of the harder textures of foods, the things that involve more chewing, bigger sandwiches, subs, chicken, especially like a barbecue chicken that it may be a little harder to chew, a steak. They go for more of the softer foods. In kids, it seems, okay, that doesn't make, like rhetorically, it doesn't make too much like it's a problem, because we know the kids like the average food, the chicken nuggets, the French fries, things like that. But when you do ask them questions around meat, it feels like it's sticking in my throat. You have some kids who are a little bit more severe at times. Food or liquid is coming out my nose. Kids will tell you Cheerios sometimes get stuck into my nose, especially during a bit major flare. You'll hear that people are coughing, their throat clearing, especially with liquid. So we've gone from the solid textures to the more of the liquid textures when they're eating. Some will complain of heartburn. Some won't complain of heartburn, but they'll still have this supratentorial sensation that something is here in my throat, but it's actually a little bit further down, more indicative of an indigestion or some pain. Some of the secondary morbidities is the kids start having a lot more low energy. They have weight loss, dehydration, poor nutrition, and some actually end up with the aspiration pneumonia. Going back to swallowing, we talked a little bit about the 3 phases, and that actually begins with when we actually put food into our mouths and we actually close the lips. We then form the bolus, which is a round substance, holding the food cohesively together, and we move it back to the palatine fascial arches in the back of our mouth. And what happens is then that movement pattern triggers the pharyngeal swallow. So that first movement after you've masticated everything into this ball takes 1 second. The pharyngeal phase has many more parts to it, which I'm going to go through in the next slide, but that all takes 1 second. And then the esophageal phase, again, the smooth muscle, the peristaltic constriction through the esophagus into the lower esophageal sphincter, for children is approximately 8 to 10 seconds in duration. For an adult, it can be up to 15, 20 seconds, depending on the age, and it gets longer as we get older. So if I look here, this is a diagrammatic. We have the oral phase. We've actually formed the bolus. We've moved everything to the fascial arches, at which point we see the palate actually elevates. At the same time it elevates, the lateral pharyngeal walls come in. So there's a valving action that then pushes down the food in the pharyngeal phase right here. If this valving action doesn't occur, that's when you will get the leakage that will come up through the nose, or they actually feel like I'm underwater or something's actually coming up into my nose or nasal cavity. Once you get the full closure, the base of the tongue makes contact with the posterior pharyngeal walls and actually pushes down. So it's a series of contractions that actually push down the food. As it's pushing down the food, what ends up happening is the larynx moves up 1 cervical vertebrae and forward 1 cervical vertebrae, at which point the vocal cords are closing and there's an epiglottic tilt to protect the larynx from food not going into the actual airway. Once that occurs, the upper esophageal sphincter now has time to open. You've actually pushed the food down, and then you start the esophageal peristalsis. When you're doing, I can't see my other picture here. That's because, let me just move this. When you do the esophageal phase, we can't forget that food can go down through the esophagus. It goes around the aortic arch, and that's where you get a lot of the patients complaining that something's feeling like it's stuck, and they have that sensation because of things going up and down, because things actually are not moving as quickly, and that peristalsis doesn't occur. In JIIM, what ends up happening is any of these weaknesses with the muscles, especially during repeated swallows, may end up with food sticking in different places, such as the vallecular space, which is here, or the piriform sinuses, which are around the actual laryngeal vestibule, and that actually can spill in to the laryngeal vestibule, causing larynx penetration or laryngeal penetration, and then if it goes past the vocal folds, into aspiration. So all in all, a series of 1 second events before you get to the esophagus, lots of different things that can happen with movement difficulties, weakness, and fatigue, because think about when you're eating, how many times you're actually swallowing. So let me just move to the next slide. So then what do we do about an assessment? How do we know what are we going to provide the patient in terms of the appropriate assessment? Well, questionnaires and an observational feeding study, some people will call it a bedside evaluation, other people will call it a clinical assessment where they give different types of foods. We have a standard questionnaire that we use at NIH that actually looks at not only yes, no types of questions, but also looks at frequency and severity of different types of questions, so we can get an idea of how often it's happening. This type of in-depth investigation helps us to trigger what is going to be the next step. Now, when it comes to swallowing assessments with speech pathologists, we typically look at the oral pharyngeal phases of swallowing, where GI will look at more of the esophageal phase, and they will look at the esophagram or upper GI series, the manometry, gastric emptying studies for those who are having more difficulty with motility, and even going on to endoscopy. For us as the speech pathologist, we will look at fiber optic endoscopic assessments of swallowing, along with what we'll call the gold standard of the video fluoroscopic study. And I'm just going to go through this a little bit. Now, what you're seeing here is actually the fiber optic evaluation of swallowing function, where you're actually putting in a small 3.2, 3.3 millimeter scope, and you're actually placing the scope right above the soft palate, and you are taking a look of the structure. And what you're seeing here is the structure. This would be the epiglottis. This is obviously the airway. And once that happens and you actually see the structure before the swallow, you're then able to feed, whoops, let me go back, sorry about that. You feed the patient a dyed food. In this case, it was green. It could be a liquid, and you would then see after the swallow. You cannot see the entire swallow because you have a period of whiteout. That whiteout happens when the palate actually closes. But then you see the after effects of, is there any liquid, or depending on pudding or cookie, sitting in the different caveats of spaces, here being the piriform sinuses here. This is a normal. Here you have a lot of food in the vallecula. Here actually normal, you just see saliva. Here you have both vallecular space and actually going around into the piriforms. You could also see after the fact if it went into the airway, because you would see the actual color green. Now, pros and cons, you're seeing both before the swallow, the actual structure, and you're seeing after the swallow, but you're not seeing the physiology during the swallow. But it is done frequently around the country here in the US by both speech pathologists and ENTs, but mostly it's a combination exam. The next exam is really the gold standard, the video fluoroscopic evaluation of swallowing function, known as the modified barium swallow. Modified being that it's not a full barium swallow, which really looks at 8 to 40 ounces of liquid barium. It allows for direct visualization of swallowing physiology. And from that, you can get a systematic assessment of swallowing with the different textures that one may eat. That being the liquid, the puree, the solid, the semi-solid. Again, we have a standard protocol at NIH for all the different diseases that we are studying. And we have multiple swallows that we do provide. We actually now are looking at medication delivery, only because I'm involved in a lot of drug research development and wanting to make sure that we can actually swallow the right type of medication formulation. At the same time, we can see the laryngeal penetration. We see aspiration, which is obviously overt. They may cough, they may throat clear. We see silent aspiration for those individuals that it goes down the wrong pipe into the larynx, goes past the vocal cords, and nothing happens. That's a little bit more concerning to us. And from all of this, and we have the impairment level, we're able to do an interpretive study from this to make the appropriate recommendations for diet. What you're seeing here is oops, sorry, once again, you're seeing swallowing, you're seeing the aspiration in the front, the laryngeal penetration. You really don't see the cough until the patient actually moves out of the way, because then they start to cough. I will write that whoops, I'm sorry of the animation issues. One more time, but you can see the aspiration, the overt coughing doesn't occur until after the fact. So it didn't really occur when something went down immediately, which demonstrates that this patient is pretty used to it by now. So then what do we do? Well, anything that I say from now on is really my information. It's really for educational purposes. And I just do have you, or I'm suggesting that you talk with your professional for each case, because we just don't know every single person. There is no cookbook. In all my years of being a therapist, I don't treat the patient the same way. I may be able to predict certain things, but no one is ever treated the same way because things work differently, and how they retain it or move on with the information, it always changes. But two basic rules of thought: when you eat, obviously you should be sitting up, not laying down. And you should stay up for at least 15 to 20 minutes if you are a normal individual before you actually would lay back down again. And obviously no distractions such as the televisions, the phones, the iPads, etc., because it can cause more problems for you. As a speech pathologist, once we've done the assessments, we have to make that decision of what are we going to do. There's a new initiative between the American Speech Language and Hearing Association and the Dietary and Nutritional Foundations on what they call the ITSE, which is the International Dysphagia Diet Standardization. This started in 2019, and basically it is a standardization around the world. So when swallowing function is assessed, we can actually use the same metrics across the board in how we are going to code. We at NIH actually just instituted this within the whole hospital system and are following it for the research as well. So it has obviously the 0 to 7 levels. There's a food level, there's a liquid level, and all of our menus and diets all follow this system. So we make that decision of what the patient can eat. Most of the time, if it's a regular diet, that's great. But then we have to make the decision, what are we going to do about the liquids? Is it going to be all liquid textures, or are we going to have to start limiting the liquid textures by way of the ITSE diets? At some points in time, depending on that swallow, we will use an interpretive scoring system. There's two of them that we will use. That one is the American Speech Language and Hearing Association's outcome measures in swallowing, which actually provides patient safety. And we've used this in our research for some of the other diseases where is the patient able to eat safely? And it's a 7-point scale that goes all the way up to whether a patient needs a G-tube, an NG2, or partial feedings with an augmentative system. It also clarifies whether they need diet modifications and where those diet modifications may be, whether it be with the solids or the liquids. We also will code appropriately in regards to aspiration and laryngeal penetration. There's another system that's standardized called the MBS-IMP, which is a system, again, looking at the different impairment levels and scoring over time those impairment levels. What the MBS-IMP doesn't have is that interpretive, where do we go from here in terms of the ability to eat and eat safety. And I kind of lean back and forth between them. I've done a lot of my research with the ASHA outcome scale only because I have worked a lot with the FDA and they like to see the change, especially with the treatments of what is the patient actually eating. But they use the impairment level as other supplemental information. So then we make those decisions. That we also have to then go one step further from a therapist point of view is, are we doing indirect therapy or are we doing direct therapy? Indirect therapy are specific postures, different types of maneuvers, such as holding your breath, calling it the supraglottic swallow. When you swallow to help protect that airway, are you actually doing more therapeutic exercise when it comes to tongue strengthening exercise, palate strengthening exercises, other types of maneuvers that could help out in terms of swallowing function? Now, let me just quickly switch gears and let's talk about voice and what we know about JIIM. This data comes back to me when Dr. Ryder and I talked about this. It hit me that, yes, I did present on this quite some time ago at ASHA. And we did a small subset of studies that looked at JIIM patients with a 27 item questionnaire. We had 97 patients, and we actually had 124 cohort of healthy individuals, again, looking at the frequency of abnormalities and vocal quality, that being not only resonance or nasality. We looked at speech rate and articulation, ranking everything on a 1 to 4 scale. So the parents completed this questionnaire. There was inter-rater reliability with the speech pathologist. So when the patient was seen, when like the day after the parents did the questionnaire, we actually were able to look at that inter-rater reliability and had some decent scores with that. The 7-item voice quality score correlated with some of the measures of myositis, that being the global disease activity, the skin global activity, distal manual muscle testing, and the CMAS. We also looked at voice scores correlating with the duration of disease and found an inverse relationship. And the voice scores were moderately responsive to change upon return visits at 9-month intervals. So we saw some interesting things with voice, and we realized that, yes, vocal quality is an issue with the JIIM patients and is not always recognized right away. So for those that don't know, dysphonia is the medical term for a voice disorder. The myositis group, it's not recognized as frequently, often goes unrecognized for months. And the symptoms are very, very varied. Generally, you see weakness, the kids not wanting to talk, they're being quiet. Most kids will talk less. They use a lot shorter phrases. Both at school, within the family, they have decreased verbal output. They definitely sound a little bit more nasal. The nasality, especially if you're getting into sentence formulation, the nasality is quite there, being hypernasal, and there's not a lot of pulmonary support actually powering the vocal cords. So in other words, a lack of gasoline powering the vocal cords. The kids are running on empty. I believe there's 3 here. These are pictures of the vocal cords, open airway here, closed during phonation. You can actually see there's a little bit of hyperfunction of the false vocal cords, and that the when they are actually talking, again, some nasal leakage that sometimes will come out. The kids will demonstrate over time with a loud voice. They're hoarse, they're pushing their voice to be heard. Some have the soft voice and a low pitch. Sometimes you hear this strangulation, almost like you have air coming out, but then it gets tight at the laryngeal level, similar to what you may hear when you actually kink a garden hose when water is coming out. The kink is at the vocal cord level. Sometimes kids, because they can't get a voice, they just go into a whispered pattern, which is more of a hyperfunctional compensatory activity. If they are aspirating or have some issues regarding laryngeal penetration, they will have the wet vocal quality as well. Here you'll see a picture, and I hope you can hear that. And those are normal vocal cords vibrating. The vocal cords themselves are like onion skins. They just have this vibration and it's very symmetrical. But if you start to strain or strangle, you're not going to be able to get it. This is video stroboscopy that we're looking at. So again, a small scope through the nose, looking down at the vocal cords. Again, ENT or speech pathologists who are trained can do this. I am just going to move this. What you're seeing here are some laryngeal images, pictures of normal cords, open, adducted. A JIIM case often will have this hyperfunction of the false cords. They're straining to get the voice. And a lot of the JIIM cases, I think 4 in that voice group that we had, ended up with vocal nodules that then get treated with voice therapy. So where do we begin? Again, with the voice assessments, it's obviously a comprehensive history of what's happening in their life, how, their home life, their school life, the medical life, and what factors are contributing. We may go for an otolaryngology evaluation, which can be a mirror or it can be a fiber optic assessment with or without stroboscopy. The stroboscopy helps us to look at the actual mucosal movements of the vocal cords. We then would refer to a voice therapist or someone who is looking at speech and voice on a routine basis. And that speech pathologist really then begins to dissect that daily function of the voice, what contributors or multi-contributors that affect. They also will interview the parents along the way, because parental and households often have different characteristics where the kids are yelling and screaming up and down the stairs, which are just adding to the overall vocal misuse or abuse. And then they will assess different parts of the voice, whether it's the pitch, the intensity, the hoarseness. There's everything from categorical types of scales. There is computer speech equipment that actually can give us a number and see changes in fundamental frequencies and different voice characteristics. Pulmonary function tests are also recommended, again, because of the respiratory function and the possible weakness. So it's a whole comprehensive set. And the questions that we ask ourselves is, when you're dealing with a patient that has these types of voice, what's causing it? Is it inflammation? Is it weakness? Is it vocal misuse? Is it abuse? Is it gastroesophageal reflux from nighttime? Are the kids on any GI meds? So again, we look therapeutically at a hygiene program, and it's not dental hygiene this time, it's vocal hygiene, the proper vocal use with the child, and also parent trying to control some of the situational events that are occurring in the house. And sometimes that involves a behavioral modification program and reward systems, and it's not financial and monetary rewards, but the kids have to work for something to get to where they want to be. We increase the respiratory support because we need that gasoline. We try to then coordinate speech onto the respiratory support, and that happens at the word level and then the phrase level, and then modulate that through conversation. If there is a nasality component, there's all types of strengthening exercises that can be done with different words. We can use different kinds of straws to strengthen the palatal regions. And I put on the bottom therapy durations. A child doesn't belong in therapy forever. I am not a believer in that. My practices never have had that. 6 to 8 weeks, you should be seeing something. And if you're not seeing something, it's that you need to then readdress, what are we doing? Too many times I'm consulted on cases, and unfortunately, the kid's been in therapy. They hate going to therapy. Why am I doing this? And it's just to appease mom and dad. So we need to make change as fast as we can. These are respiratory, expiratory, and inspiratory trainers. It's both. It's not only increasing how much air we take in, it's how we also let the air out. And these devices, and they are available, and we use them quite frequently with the kids, because it's something that they can see and see the change over time, have different resistance levels, and that actually helps. So some take-home thoughts: both swallowing and voice dysfunction should be included in the initial history and physical of JIIM patients, as well as during reassessments. If bulbar weakness is evidence, probe and investigate the speech and swallowing issues even further, because they're usually there. You have to start asking about specific foods, because if you just say, how you doing swallowing? I can swallow. Oh, do you ever cough when you eat? Oh yeah, occasionally. Well, do you clear your throat a lot? And you have to mimic a lot of this, and that may be the start of your referral. Consider your early referrals, not only to speech, but to ENT and GI if needed. And if persistent hoarseness following a flare persists, again, you got to look at the further assessments and treatments. In lieu of time, I'm going to stop here and answer any questions.
Thank you, Beth. We've probably only got time for 1 or 2 questions, so if people can post them in the chat box. And can I just remind the presenters, when you're answering a question, if you could read the question first, because we're recording this and the answers become nonsensical unless there's a question at the start of it. Thank you.
I'm not sure I'm seeing anything there.
There isn't anything
Oh, I didn't think so.
popping up on my screen. So just perhaps in the interest of time, if anybody has any specific questions for Beth, as I indicated at the start of the meeting, you can direct them to me and I'll ensure that I connect you with Beth.